gastroesophageal reflux. When we say Gerd, it means gastroesophageal reflux disease. PPIs is proton pump inhibitors. Gastroesophageal reflux. نبدأ بالتيم ليدر عنود. What is a gastroesophageal reflux?
Can you hear me, doctor?
No, I didn't hear. Again, please.
It's when you have a reflux of acid into the esophagus from the stomach.
So when I move the screen, you don't see the slides anymore now?
No, now we can't see it.
Can't see it, okay. That's okay. So reflux of acid, from where? From the sinuses, the nasal sinuses?
From the stomach to the esophagus.
From the stomach. Okay, Tala, what do you think?
Yes, doctor. About what is GERD?
Mm-hmm.
Yes, I do agree. And also it's due to like sometimes a complication. Maybe the sphincter, the lower esophageal sphincter is loose.
Okay. So the lower esophageal could be loose. You know, academically, when we talk about the definition, this is a sentence that, you know, defines something. When you have this sentence, so it will be a comprehensive sentence that explain it and makes it distinguished from other, you know, definitions or diagnoses. So there might be reflux of non-acidic material. This is one difference between what Anud mentioned. Tala mentioned one of the mechanisms of the gastroesophageal reflux, how it happens, but it is not a definition. We want to define it. We can define it as follow. So it is the condition that develop when a reflux of stomach content. When we say stomach contents, we mean acid and non-acid, causes troublesome symptoms and or complications. What is the meaning of the third line here? Troublesome symptoms and or complications. Sometimes you have reflux which is physiological, which is within normal. To say that this is a disease, this is a pathology, it happens when you have troublesome symptoms, and sometimes patient might have no symptoms, but there are complications from this disease. Physiological reflux, it happens most postprandially, short-lived, usually asymptomatic, rarely occur during sleeping. So what is erosive esophagitis? It is characterized by endoscopically visible breaks in the distal esophageal mucosa with or without symptoms. And I want to put both screens together, but I don't know what's happening today. So we can see you and see the slides.
Doctor, do you want me to share the screen instead?
Yeah, could you share the screen of the people? How can we? You share my screen? My slide?
Yes. Yeah.
The slides are different. The slides are a little bit different, you know.
Okay.
Anyhow, carry on. But could you participate, all of you? We will move to the next, and then you help me participate. Okay. Epidemiology, it happens 10 to 20% of population. So back to the definition. Nabi Adnan. عدنان. طيب أحمد. شباب صحصحوا معنا, please wake up, huh? We need all of you. عدنان, أحمد, please wake up. من اللي بعده؟ عنود من هذا اللي بعد أحمد؟
آلاء.
آلاء، واللي بعد آلاء؟ يلا آلاء. Could you define gastroesophageal reflux again, please?
It's a disease when we have reflux of the stomach contents, either if they're acid or bile. It causes troubles swallowing and troubles something like burn.
Okay, ممتاز. طبعا necessarily you say bile. Stomach contents, either acidic or not acidic. It could be bile, it could be stomach content of food or anything. Not necessarily also bile. So reflux of stomach content or regurgitation of stomach content from the stomach to the esophagus that causes either troublesome symptoms and or complications. So this is the definition. This definition we take we include silent reflux, somebody who has no much symptoms but has complications. We exclude physiological reflux, which happens briefly postprandial and these kind of things. The definition, it includes what other which is out. Going back to the slides, and please find me Adnan and Ahmed, and we want you all to wake up. Adnan, Ahmed, you have to find them, please, and you have to participate. We will move back to the slides. So erosive esophagitis, when you see breaks, erosions in the distal esophagus. So epidemiology is 10 to 20% of population. The pathophysiology of reflux is interesting. As Tala mentioned, one of the important mechanisms of development of reflux is the competency of the lower esophageal sphincter. If you have lower esophageal sphincter pressure, or you have transient lower esophageal sphincter relaxation, TLES is lower esophageal sphincter. T transient, LES, R is relaxation. TLES, which is transient lower esophageal sphincter relaxations. The lower esophageal sphincter might be competent, but it may relax for a brief period. And that is within allowed physiological relaxation. But there might be a pathological TLESRs, which is long or more frequent. When we have increased distensibility of the esophagogastric junction by distension of the stomach, this relaxes the lower esophageal. The presence of hiatus hernia relaxes the lower esophageal sphincter. So one of the very important factors in pathophysiology of reflux is the lower esophageal sphincter competency. Then we look into the stomach content. Could be acidic reflux, gas reflux, duodenogastric reflux, which is bile, or how much extent of proximity the refluxate goes, and is it gas reflux? Now, because the definition includes the symptoms and what patient feels, there is peripheral sensitization of the feeling of reflux because it is bothering the patient, and there is the central perception of that bothersome or pain. If we could control the peripheral sensitization in some occasions or control the central sensitization, this could help in management of gastroesophageal reflux. It is the mucosal integrity. When you have a patient in the ICU with decreased perfusion to all the organs, including the esophagus, this patient might be easily develop complications of gastroesophageal reflux and develop erosive esophagitis. This is why you have stress ulcers in the stomach with patients in the ICU. There is a theory called acid pocket theory, which means that the acid tends to sit contents. When you have delay in gastric emptying, you have the food sitting in the stomach for longer than usual, and this may cause increase the chance of having reflux. This is why some times we give prokinetics to the stomach. And obesity increases the intra-abdominal pressure, and this in turn causes more reflux. So TLESR is transient lower esophageal sphincter relaxation. It is physiological when it is short, less than 1 minute. It causes gastric content to move from the region of high luminal pressure in the abdomen area of low intraluminal pressure of the chest. Happens more in awake postprandial status. What is important about hiatus hernia? The lower esophageal sphincter is thick muscle, lives at the diaphragm pinch, and there is the angulation of Hess here. When you have hiatus hernia, you lose the crura of diaphragm pushing at the same area of the lower esophageal sphincter, and you lose the angle of Hess. So you can imagine with hiatus hernia and part of the stomach escaping from the abdominal cavity to the thoracic cavity, you can imagine the lower esophageal sphincter would be more lax. Symptoms of reflux. يلا لقيتوا لنا عدنان واحمد. عدنان واحمد say hello to them. Tell them to meet me tomorrow in the شو اسمه North Tower 5th floor. عدنان عبد الكريم وأحمد آرو سميث. طيب علاء الدين بربور.
Yes, doctor.
علاء الدين, tell me what are the symptoms we have in reflux?
Hello?
What are the symptoms of reflux of Gerd?
Heartburn, coughing, chest pain.
Heartburn, coughing,
regurgitation.
coughing.
Can you hear me?
You mentioned coughing. Yes, I hear you.
Yeah.
You mentioned coughing. Is it right?
Sorry?
Did you mention coughing?
Yes.
Okay, cough, chest pain, wheezing. So some of them are typical, which is heartburn and regurgitation. Some are atypical, which is cough, wheezing, and these kind of things. Also, examination, patients will look the same. No specific things in examination, no special features, but they might be obese. As we mentioned, obesity increases the chance of reflux. You may see a pregnant lady. Pregnancy increases esophageal reflux at the 3rd trimester because of many mechanisms. The pressure of the baby and then the progesterone also causes some relaxation in the lower esophageal sphincter. You may see also by examination that the patient has connective tissue disease, in particular scleroderma, and part of the disease is a peristalsis, no peristalsis of the esophagus, and this leads to gastroesophageal reflux. You may look into extraesophageal symptoms such as wheezing, cough, or recurrent sore throats. How to diagnose gastroesophageal reflux disease? This is interesting now. We will move to العنود. نرجع لك مرة ثانية. ممتاز. جاوبي العنود. How can we diagnose reflux?
To diagnose, first you look for the symptoms of gastroesophageal reflux disease.
Mm-hmm.
And then you can do a pH monitoring, barium swallow.
Typical symptoms. Okay, so diagnosis is something that you do to label the patient. This patient has a disease. How can we diagnose hypertension?
Yes.
It is not only one reading. For example, high blood pressure. There is a criteria. You have to measure that patient should be not recently running or not under stress or in pain. You have to measure the blood pressure several times. So there are some criteria to diagnose a patient with hypertension. Okay.
So you monitor the patient's symptoms.
Yes. Say that you have a patient with headache. Could you diagnose him with hypertension? Taking history of headache? No. The same thing for reflux. So, for example, in bronchial asthma, is it necessary to do chest X-ray and some physiological studies to the lung diagnose bronchial asthma, or you can diagnose it clinically. Some diseases you could diagnose clinically. So gastroesophageal reflux disease, one of the way of clinical diagnosis is typical symptoms, that is heartburn or regurgitation, not sore throat or cough, that you give them enough duration of the appropriate medication at the appropriate timing, and then respond well with good response, which means very satisfying results after they are giving PPIs, proton pump inhibitors, for example, omeprazole. This is a way of diagnosis. It might not be very sensitive and specific like the others, but it is a way of diagnosing reflux, because you have a disease that affects 20% of population. You cannot do testing for all of these 20%. You should have an easy way to diagnose it. The other way is doing endoscopy, logical, and you see erosive esophagitis.
سوري أقاطعك دكتور، بس صوتك شوي يقطع.
Okay. You do endoscopy and you see erosive esophagitis. واضح الحين؟
إي واضح.
أي من اللي يتكلم؟ من معي؟
العنود.
العنود. طيب العنود third way of diagnosis. You mentioned pH study صح؟
pH study إيه.
swallow. Histopathology of مثلا Barrett's esophagus. So what is NERD? Non-erosive reflux disease or and gastroesophageal reflux disease. نبي نشوف نمشي. يلا فاطمة. فاطمة ماجد. زيد سعيد. يا جماعة فاطمة and زيد. But I don't know the participation today, the usual, So are you getting bored from the COVID and the online lectures? علا? امشي بالترتيب يا جماعة جلوا شلون. عنود could you go through sorry لا دقيقة عشان بس نكمل الليكتشر صح كذا كل الشباب مو موجودين. العنود امشي على الأسماء واحد واحد و see who's present who's absent.
تمام.
امسك بورقة لو سمحتي. We will have a list of absent people. We have to have an action.
تمام.
Okay يلا أنا معك. We'll pause for a while بس take the names.
اوكي عبد الله الأخبري.
اوكي مو موجود absent. next.
عدنان.
absent. أحمد absent. بليز كلهم بدون مجاملات لو سمحتي عنود ها. It makes a difference. You can read always. You have all the sources open, but you're required to do something. You have to do it the right way في حقيقة. فالشباب اللي ما حضروا we will not go back and see. خلاص اللي ما حضروا we will have a complete lecture for them. نتكلم معهم بقابلهم إن شاء الله وجه لوجه ونتكلم في الموضوع. فgastroesophageal reflux Gerd versus NERD. I will carry on now. Please participate. Please make it active and please ask. Non-erosive reflux disease is when erosions in the esophagus. There is no breaks. So in contrast to erosive esophagitis, when you do endoscopy erosions, you see some ulcerations at the distal esophagus. So that is the difference between Gerd versus NERD. Gerd is the general term. It's NERD and erosive esophagitis. NERD means non-erosive reflux disease. So have a look to this slide. I will just excuse you for a minute. Okay, so going to the slide again. Risk factors of having Barrett's esophagus. Barrett's esophagus is change of the mucosa of the lower esophagus from the squamous to the columnar epithelium. It happens with some risk factors such as duration of Gerd more than 10 years, or adenocarcinoma. Why to start with EGD in dysphagia? When you have dysphagia, you have to do endoscopy for the patient because there might be anatomical narrowing that is benign or malignant stricturance or tumor, to take a biopsy to rule out esophagitis and to rule out Barrett's esophagus in long-standing Gerd. The endoscopy is a tube that has a camera and a light source, and you can examine the stomach and the esophagus, the lower esophageal sphincter, the competency of the sphincter. When you have dysphagia, you have to do endoscopy. Los Angeles classification of esophagitis is 4 grades for erosive esophagitis: grade A, B, C, and D. A is mucosal breaks less than 5 millimeters, not crossing the mucosal folds. B is long breaks, and C is crossing the mucosal, but less than 75% of circumference, and D is more than 75% of circumference. طيب من عندنا يساعدنا هنا لو سمحتوا آية.
Yes, doctor.
Aya, tell me from this picture, and be with me, please, for the questions, so we make it more interactive.
Okay.
What do you think? What is the grade here? If we go back here, A, B, C, D, you see, try to see the folds. This is a fold, and this is another fold, third fold, and there are some erosions here, and you can see the erosions crossing here. So from the classification here, do you think it is A, B, C, or D, or none?
I think it's D because I can see the ulceration.
Yeah, so it is involving more than 75% of circumference. It is a circumferential erosions. You can see something very interesting also, Aya. We're looking from up to down. This is the gastroesophageal junction. And here is another thing here, another plan here, which is the diaphragm pinch. This part is a stomach, which is above the diaphragm. This is a hiatus hernia sac. You see this structure here is part of the stomach herniated above the diaphragm. So this makes this patient having very lax lower esophageal sphincter due to the hiatus hernia, and this leads to a bad erosive esophagitis. So this is erosive esophagitis. It's not non-erosive disease, and D, correct. Barrett's esophagus, a change of the distal esophageal mucosa from squamous to columnar epithelium. This is the look of the esophagus. It is red color mucosa, but it is not erosions. هذا مو جرح. Again, you can see a hiatus hernia. You see the diaphragm pinch here down, and you see the esophageal junction here. There is part of the stomach above the diaphragm, and there is no erosions, no ulcer. This is just change of the color of mucosa. When it was squamous, it is pink. When it became columnar, it is red. And this is Barrett's esophagus, a salmon-like mucosa at the distal esophagus. واضحة آية؟
Yes, doctor. Yes, it's clear.
طيب, clear. خلينا نشوف من يساعدنا الآن. نبي ناخذ. تغير الترتيب شوي. همسة.
Doctor, may I ask a question?
Yes.
Sorry for interrupting.
تعالى.
Yes.
تعالى we'll take the question. بس همسة أنت معنا؟ همسة أحمد. Please تكفون يا جماعة. Participate. Be with us. ها؟ طيب كم من ناخذ؟ مازن؟ أسامة؟
I'm here, doctor.
أسامة. طيب أسامة بس be with us على ما ناخذ السؤال من تالا. تالا تفضل.
مازن مو.
إيه. مازن طيب بس تالا السؤال لو سمحتي.
Doctor, هلا for the slide that had the grade D and this slide, both of them, they have the color red. So the only difference is that one of them is patchy and one of them is like linear, sort of.
Yeah. So here the erosion is very pale and eroded from the mucosa. There's a break in the mucosa, and here you see this is the erosion. هذا الجرح هنا, and the esophagus is pale, is pink in color. You can see this is the esophagus. This area, which is the affected area, is very red, very salmon color mucosa, أو برتقالي تقريبا. عرفت? Orange, almost orange. Is that right? And this is pink. You get the point. This is intact mucosa. It is not pricked, like you have this in a skin, or you have an ulcer in the skin. This is an ulcer. You get the point?
Okay, it's clear. Yes, it's clear. Thank you, doctor.
Thank you for clarification. This is, if you see this is common in exams, by the way. In maybe residency fellowship exams, they put Barrett's esophagus. You put the typically of a patient with large hiatus hernia, obese, smoker, male, and then they will tell you this is the finding. What do you think is the finding? And here is erosive esophagitis. You know, when you leave this, when you treat the esophagitis, it will heal. It may progress to be Barrett's esophagus. طيب مازن ولا من اللي كان معنا مازن؟ Yeah, Mazen, you see, one of the way of examining for hiatus hernia is doing endoscopy. We take the scope, we bring it in the stomach, and we bend it around itself. We call this retroflexion view. Okay, واضحة?
Yes, doctor.
Okay, now we are doing a retroflexion. This is the diaphragm. You can see the dome of the fundus of the stomach is above the diaphragm because of the big hiatus hernia. And that is causing a big part of the stomach to be above the diaphragm. This is about maybe 5 centimeters in length. We call it large hiatus hernia. And when you do the retroflexion, you see this image. This is the scope. So you're looking at the scope like the snake looks into its tail. You're looking into the scope, and you can see the scope is the area around the scope is widely open and competent. If you compare it to this competent gastroesophageal junction, when you have no hernia at all, you see it is very competent lower esophageal sphincter. واضح يا مازن؟
نعم دكتور.
أيوة. This is why when you see endoscopy, you see that they comment on hernia. And this when you do barium was very easy, logical to see a hernia. Some part of the stomach is above the diaphragm, but it is not like the other methods to detect hernia. Small hernias may be missed by barium swallow. Manometry is another way of detecting hernias. What you do is, this is a swallow, this is another swallow, a little bit weaker than usual swallow. Manometry is a pressure sensing study. Red is high pressure, blue is low pressure. The time goes from left to right. Here is a swallow, here is another swallow. When this is the upper esophageal sphincter, this is the lower esophageal sphincter. You can see the sphincter has competency, has a pressure more than 80 millimeters mercury. You can see it here. When the patient is swallowing, it becomes blue. It becomes blue here because the patient is releasing the upper esophageal sphincter and is moving the esophagus. This is the lower esophageal sphincter tone. You can see another pressure line here. Mazen, إيش رأيك? What is pressure line here?
Your voice was cutting, doctor. Can you repeat the question?
What is the pressure line here? What do you think?
It looks like it's low pressure.
Yeah, I mean, what the structure is there at the area of the arrow?
The lower esophageal sphincter.
So here is the lower esophageal sphincter. There is something below the lower esophageal sphincter. What could
Doctor,
this be?
I think the diaphragm.
Diaphragm. طيب, this is how it is the diaphragm. How can I prove that? You see, the patient here makes the blue more black. That here it is more black than this one. If you are seeing it from a screen, a computer screen, it will be clear. This is black because the patient is taking deep breathing and increasing the pressure from 0 to below 0. And here it is more of green because when he's taking deep breathing, he's pushing the diaphragm, and here's the diaphragm pinch. Here is the intrathoracic negative pressure. Here is the intragastric positive pressure. So this is the diaphragm pinch here, the lower line, and here is the lower esophageal sphincter, the upper line. So there is a separation between the two lines, and this is hiatus hernia. You know, when you see here, if this catheter, imagine that the scope catheter is a manometry catheter. And imagine that you have a line here at the lower esophageal sphincter. You will see another line, the diaphragmatic pinch. But in this case, when you have both of them at the same area, the diaphragm and the lower esophageal sphincter, you will see no separation between the two lines. واضحة؟ Crural diaphragm pressure and lower esophageal sphincter pressure, and this is a hiatus hernia. واضح مازن؟
ايوه دكتور.
يا هذا البوز كأننا تذكرون مكالمات أمريكا، أول تكلم شوي ويرد عليك. بليز ركزوا معنا يا جماعة. pH monitoring. So pH monitoring is a meter in the esophagus that measures the pH, the acidity in the esophagus. You can use a catheter or you can use a capsule, wireless capsule that you the lower esophagus. pH study has three components: how much acid in the distal esophagus, how much non-acid material, and what is the correlation. How much acid? 4% or more is high acid. Some reference is 6%. Normal is less than 4%. Normal, so if you divide the 24 hours percentages, more than 4% sensation of acid in distal esophagus is high acidity. عنود واضح هذه؟
اي دكتور.
So 4% is almost 1 hour per day. 1 hour of exposure to acid in the distal esophagus is allowed. Some references say 6%. For the non-acidic material, 1.4% is in the total hours is allowed. More than that is high. Symptoms correlation. If you have 50% or more of the symptoms are correlated with a reflux episode, this is correlation. For example, 16 times heartburn. 16 times heartburn, 10 of them with reflux. This is correlation of what? 10 over 16 is 62. And this will be positive correlation. صح ولا لا؟
دكتور
ايوه تفضلي.
Okay, I have a question. Don't mind. مزنة
تفضلي.
Can you please repeat the part when you said if more than 4.2% of total 24 hours, then you said they measure 1 hour. I did not get that.
Yeah. إذا عندك آلة حاسبة, divide 1 hour divided by 24. 1 تقسيم 1 divided by 24 will equal by percentage 4.2%. يعني in the 1 hour out of 24 or 1 out of 24 is 4% almost. You get the point?
Okay. Yes, I get it. Thank you.
So it is either you make it by minutes or you make it by percentage. Why we don't make it by minutes? Because sometimes we don't complete 24 hours. We do 22-hour study, 23 hours. So for a reason of comparison between different patients, we take it percentages. Add to this also, we delete the time that the patient eats or drinks. Say that the patient is drinking lemon juice for 2 hours during the day. It will give you high acidity for those 2 hours. We delete that time, while the active time of drinking. Is it clear?
Doctor, is it okay
Yes,
if
yes,
you give us an example to know like how are we supposed to
Yeah, we
divide
will come to this. We'll have an example. Yeah, we'll have an example now. So the percentages, the symptoms correlation. If you have heartburn 6 times, half the times is associated with reflux, half the time or more, this is positive correlation. So 10 times this is positive. فمثلا علميني ايش رايك 16 times heartburn. احنا نعطي المريض زر. He will press the button when he feels that there is symptoms. And we can make
Yes.
at the time of pressing the button, was there really reflux or not? So say that there is 16 times, 5 of them were having a real reflux at the same time. This is 5 out of 31%. What do you think? This, if it is positive, this
معلش
one
بس
will be
صوتك
what?
يقطع.
Sorry. So
ما سمعت.
16 times, 16
Yes.
times heartburn, 5 times associated with reflux. Would this be positive or negative correlation? ايش رايك؟
Negative correlation, but I don't know why.
Negative. Okay, good. So you don't know why. The cut limit is half the time. So if you have heartburn 16 times, the patient presses the button 16 times. If 8 of them are having reflux at the same time, or 8 or more, this is positive correlation. أعطيك إياها بلغة سهلة معلش. I will tell you. Say that some patients press the button 100 times. I have heartburn. From that 100, let's say 99% of times there was real acid. So this is correlation. صح ولا لا؟ 99 مرة. إيه. طيب. If the patient have the heartburn, they press the button 100 times. Only 3 episodes were associated to the reflux, while 97 episodes are not associated with reflux. So this is negative correlation.
Yes.
بالضبط. So what the limit is 50% or more. Is it clear now?
Yes,
Okay.
yes, clear.
So this is a very interesting slide. You go anywhere, you will see this slide. The extreme left is erosive esophagitis, a patient who has a lot of acid exposure, a lot of acidity by pH study, 0 symptoms. Because yellow represents acid exposure and red represent sensation or symptoms. Okay? فنبي أحد يكون معنا بس عشان نشرح هذا. مزنة؟
Yeah.
Mizna. So
Yes, doctor.
Here, the extreme left is, I will tell you, I will give you an example, you tell me, here, extreme left, or here, or here, or here. Okay?
Okay.
Old man had endoscopy because of an ulcer in the duodenum. And there was grade D erosive esophagitis by endoscopy. You finish the test, you wake the patient up, you ask him, do you feel any heartburn in the last 10 years? He will tell you, no. I feel no heartburn, I have no problems. What brought me to the hospital is melena. I feel no pain at all. So what do you think is this? Is it here, sensation, or here, on the left or on the right?
On the left.
So yes, extreme left, correct. طيب, I will can example, another example. You have a boy who is 18 years old, going to his secondary school examinations before going to college, and he is usually fine, has no symptoms. But before exams or under stress, you will feel some heart and chest pain. You did pH study. It is showing 0 acidity in the esophagus, but he has a lot of pain. What do you think? He'll be here.
Esophageal hypersensitivity.
So the extreme right, correct.
Yes.
So if you draw a line here in the middle, left of this line in this area is gastroesophageal reflux disease. Right of this line here is functional feelings with no much of acidity. So the extreme right is easy, the extreme left is easy, but the middle area might be a little bit difficult. Here you may have gastroesophageal reflux with some erosions by endoscopy. You may see some patients with normal endoscopy, no erosions, but they have high acid exposure. You'll be asked by many friends, I had an endoscopy, my doctor told me that it is normal, but still I have a lot of symptoms. I have reflux. I'm sure that I have reflux despite a normal endoscopy. This could be a non-erosive reflux disease because the acid is high, but the endoscopy is normal. When you move a little bit to a very interesting entity called reflux hypersensitivity. نبي نرجع لعنود. عنود معلش, you are the team leader, you have to be with us for purpose just of interaction and to make it easier to understand. Reflux hypersensitivity, what is that? You see a patient here who has positive correlation. مثلا, he has heartburn sensation 30 times. 27 of them associated with reflux. So very high positive correlation. Okay? But when you measure the actual time of acidity, it was only 20 minutes per day. 20 minutes is less than about 1.8% or 2%, something like that, of acid exposure. So the acid is not high, but the correlation is positive. This we call it reflux hypersensitivity. واضحة? Okay. So treatment of these, we'll talk about them after we finish talking about it. There is Lyon consensus, is an consensus about reflux diagnosis. Conclusive evidence of pathological reflux is grade C or D esophagitis, long segment Barrett's mucosa, peptic esophageal stricture. Our acid exposure, AET is acid exposure time. Acid exposure time more than 6%. So this good evidence of reflux. When you plan take a major decision such as doing surgery for reflux. Surgery for reflux, by the way, Mazen, what surgeries we do for reflux?
Doctor, can you repeat the question?
What surgeries do you as an option of treatment of gastroesophageal reflux?
Maybe tighten the sphincter a bit.
Yeah, what is it called?
Sphincter. Got its name though.
It is. Sphincterotomy is for the opposite, for the sphincter which doesn't want to relax, which is called for achalasia. Sphincterotomy is for ERCP and cutting the sphincter of OD. Myotomy is cutting the sphincter of the lower esophageal sphincter with achalasia, but we call it fundoplication, which is wrapping the fundus of the stomach around itself, called fundoplication. When you want to take a major decision such as fundoplication, you have to have a good evidence of having reflux by very positive conclusive evidence, grade C or D esophagitis, acid exposure more than 6%, or presence of Barrett's esophagus or peptic stricture. Borderline or inconclusive evidence, this is grade A or B esophagitis, acid exposure between 4 to 6%, or the number of episodes by the pH study of reflux 40 to 80. Adjunctive or supportive evidence, this is some histology changes of inflammation and electron microscopy, changes of inflammation. So there is something called mucosal impedance. Anyhow, this is just something advanced for you to have a sense how do the people think. And Lyon consensus was something important in reflux. I thought to put this slide also. When you do manometry, you see hypotensive lower esophageal sphincter, you see hiatus hernia. Now, evidence against reflux if you have acid exposure less than 4%. So this is an example. من اللي قال example?
I did, doctor.
يلا مين أنت؟
أنا تالا.
يلا تالا ساعدين. 18-year-old female with chest pain before exam. Total acid exposure is 2.2%. This is about 30 minutes per day. طيب. No reported symptoms by the patient. What do you think? This is positive or negative study for acidic reflux?
The 2.2 you mean?
Yeah.
It's negative because it's normal.
Right. So normal study or versus false negative. Sometimes it might be sample A of a good day. Maybe the patient has some reflux once or twice a week, and at this time the patient did not report any symptoms. So it might be just a sampling, not a sampling good day among bad days. So this is an example. So patient will, if this is really representing all the days of the year, this is functional heartburn. For Bassetala, tell me about this patient, 70-year-old male with chest pain, normal endoscopy. Normal endoscopy means either no reflux or non-erosive reflux disease. صح ولا لا? There is no erosive esophagitis. صح يا تالا?
Yes. Yes.
Okay. So he stopped PPI 1 week, you did pH study, and you see the following. Total pH is 11%. يعني هذا لو جينا اليوم consensus, لو جينا not borderline, it's not conclusive, even above 6%. صح ولا لا? By all means, it is positive. Yeah, it is positive.
Yes.
So, and he reported 12 times episodes of chest pain. 9 of them were associated with reflux. This is positive or negative correlation?
It's positive correlation.
Okay, yes. What is the cut limit of between positive and negative correlation in this particular patient?
It's 50, and so the patient here has 75, so it's above 50.
Yeah. So what is the cut limit of numbers? How many episodes out of 12 should you have to have a positive correlation?
I think 6
correct.
Or 7.
So, yes, yeah, 6, correct. So more than 6. This is gastroesophageal reflux in the form of non-erosive reflux disease with correlation, and the patient lies here in this diagram. Okay. Impedance study, just for your interest to know, you hear about pH impedance, manometry impedance. Impedance study is an electrical study that you measure the changes in electricity. You see the changes here in the electrical sensation by these electrodes. So here, the changes happened up before down. This is upper esophagus, this is lower esophagus, proximal esophagus, distal esophagus. You see, if I draw a line here, these changes happen up before down. So this is the patient drinking a material that conducts electricity, either acidic or non-acidic material. And here is the refluxate of a material that conducts electricity, because changes happen down before up. This impedance study is used if we want to measure the changes of electricity that happens with acidic and even non-acidic material. So if a patient is on PPI, doesn't want to stop PPI, I can do pH study and impedance study. So in the catheter of the pH, there will be a sensor for pH and some sensor for electricity. And this will give me a number, an impedance value. This is the value that we measure here by non-acidic reflux, the bolus exposure, we call it. More than 1.4%. So this is the impedance. Just, something, it is advanced, I know, but for you to know, how can we do a pH study on treatment, or how can we utilize the changes in electricity in measurement of impedance. Treatment, lifestyle modification advice by raising the head of the bed 30 degrees, decreasing weight, smaller meals, not to lie down 3 hours after eating. Maybe avoid caffeine, chocolate, mint. Antacids, H2 blockers such as ranitidine, proton pump inhibitors such as omeprazole, surgeons such as sacral feet. Procedures. There's a procedure called strata procedure, which is radiofrequency treatment lower esophageal sphincter. It is not so effective. There is link system, a magnet that is attached to the lower esophagus. It is an option, but you put a foreign body here, which may cause fibrosis. Many surgeons don't like this procedure. Some surgeons, thinks that it is an option. Or there is endoscopic fundoplication, and there is the usual known fundoplication, either Nissen's fundoplication or Toupet fundoplication, or any kind of wrapping the fundus of the stomach around itself. You don't want to go to surgical options if you have a patient here in the extreme right. صح ولا لا؟ واضح هذه يا جماعة؟ Tala?
Yes, doctor.
Yeah, say that you have a patient functional heartburn. You don't want to send them to surgery. This is, very, very clear. The treatment here in the right extreme is decreasing the sensation. Here in the functional heartburn, we give them selective serotonin reuptake inhibitors as a treatment of sensation in the esophagus. We are not giving for depression or anxiety. There is good evidence that it helps in decreasing the sensation in the esophagus. Reflux hypersensitivity, we give some pain medications such as SSRIs, and we give them antacids or PPIs as needed. Here in the extreme left, the old man, we give him treatment despite having no symptoms, and we monitor him by repeating endoscopy because he is feeling no symptoms. Here we give medications, PPIs, we give surgical options. It's all possibility of treatments. In the past we have one treatment, one size fits all. Now we try to individualize treatment. You will see somebody going in the TV talking about the harm of PPIs. It's different. The old man on the left extreme, if you don't give him PPI, he will end up with complications. On the right side, no, you better avoid giving a lot of medications. So the key is giving the minimal duration, the lower dose possible for medications. Complications of Gerd, peptic stricture, Barrett's esophagus, erosive esophagitis, cough, laryngitis, media. Side effects are many. Some of them are not proven, but you avoid medications. It's not needed. If it is needed, you better give it rather than getting the complication of the disease. How too long? The shorter possible period, minimal effective dose. Some patients require long life PPIs. There are additional reading Gerd guidelines. We have 2021 new guidelines. This is the old one, 2013. You can look into the new ACG guidelines also. And thank you very much for your time. I apologize for reading the names, بس صدقوني من حرصي عليكم و sorry for that. Any questions? I'm willing to answer here, or you can reach me in the clinic. You are most welcome if you have any question.
Sorry, doctor, I have a question. So for the is there a specific type of classification we are required to memorize or no during our level, other than the two you have mentioned already?
So I think for your level, can you see the Lyon consensus is agreed upon classification for diagnosis of Gerd, and you can see this slide also. Okay, and the third one is the ways of diagnosis of reflux, which is this slide. Symptoms, erosive esophagitis, pH monitoring, PRM. So these are the ways of diagnosing reflux.
So we follow these according to the symptom and severity, and we decide.
Exactly.
Okay, thank you so much.
Thank you very much for coming. ونشوفكم على خير إن شاء الله. Anud, please send me the names of people who didn't attend. Write in the email. This is by my request that and send it to Shara and the CC. بدون مجاملات معليش. أيوة.
السلام عليكم دكتور، عفوا هنا همسة دبيكي، همسة سيد. بس دكتور عفوا أنا I couldn't reply because my internet connection is not stable.
Usually, I will compensate. Hamza, don't worry. I will do compensation for you. Not, يعني I will try to meet you in another time. Take a brief